Hello, my name is Arjun Sinha from the Circulation COVID team. I'm a cardiology fellow at Northwestern in Chicago, Illinois. Today I'm joined by Dr. Dorairaj Prabhakaran, who's the Vice President of Research and Policy at the Public Health Foundation of India. Dr. Prabhakaran is a cardiologist and an internationally renowned epidemiologist. I'm also joined today by Dr. Anurag Agarwal, who's the Director of the Institute of Genomics and Integrative Biology at Delhi University. Dr. Agarwal is a pulmonologist and critical care physician with a doctoral degree in physiology. Dr. Prabhakaran, Dr. Agarwal, thank you so much for being part of our initiative, Circulation COVID, Updates from the Front Lines. We would love to get your perspective on how your center and India at large have led initiatives to battle COVID-19. Dr. Prabhakaran, we'll start with you. Can you comment on why India has not yet been a major hotspot, despite having a very high population density?
Thank you, Dr. Sinha, for having me on this program. I think there are multiple reasons as to why India has done very differently from many of the Western countries. First, actually, we need to have a little bit of background. The first case was reported on the 31st of January, and we reached 100 cases by the 15th of March. The first 3 cases actually came from Wuhan. They were returning students to Kerala, and the Kerala government started contact tracing and quarantining and isolating people. And they did a very aggressive contact tracing initially. Then as we reached the 100th case, the government all across the country banned big meetings, mass meetings. They imposed something called Section 144, which means that not more than 5 people can gather at a public place. This was on March 15th when 100 cases were reached. Then by March, and then they also had started screening international travelers who were arriving, particularly from countries which had very high case load, like Italy, for example. And people, there was thermal screening at the airports, and people were advised to self-quarantine. By March 22nd, the country went into a complete lockdown. And we hope that there will be a calibrated reduction in the lockdown. Apart from the lockdown itself, there are other reasons. One is there is a high degree of heterogeneity and variability in this country. This is, India is of continental proportions. As you know, each state is almost like a European country. And each of the responses have been different. The health system response have been different. And many states that have had prepared very well in terms of the health system are doing very well. The other thing currently, many states have actually truly flattened the curve. For example, the doubling time in Kerala is 72 days. And even if there is infection, there's a need for emergency admissions and so on. You have enough wherewithal to handle that. The average doubling time in India has come to 10 days. Now, the other things that have been done, particularly for contact tracing, is using technology. The government has created something called Arogya Setu, which means Health Bridge. And that's a kind of GPS-enabled system which can actually trace all the contacts. Then there's continuous data provided by modelers who across the country for states as well as for the country on the whole. And in fact, my organization, the Public Health Foundation of India, is providing a lot of support in terms of modeling data. Then the government has created COVID hospitals, and several other things have been used. Other putative reasons also have been identified. One, India lies very close to the equator, and as we all know, many people have been talking about countries which are closer to the equator have lesser number of cases and lesser mortality. The second is, they say that the mortality is low because the natural killer cells in Indians are supposed to be active because of multiple infections that they've had during childhood and so on. It's also been shown that India is in the malaria endemic zone, and some of countries within the malaria endemic zones have less number of cases. Another theory put forth is BCG, universal BCG vaccination. All these need to be proven, obviously. But clearly one thing that is emerging is that the mortality rates which have increased during this month or during this period in other countries has not been observed in India. And there has been a lower mortality, and maybe that is because of low mortality due to air pollution, reducing air pollution, or reducing road traffic accidents, and so on. So these are some of the reasons I would attribute to the way things have been handled, the lesser number of cases and lower mortality. Of course, on the flip side, people have said that the testing rates are pretty low, and that could be one of the reasons. But if you look at states which have very high testing rates, even there, the cases are not huge.
Yeah, that's really interesting. In terms of cardiovascular effects, do you have concerns about short-term or long-term cardiovascular effects that the lockdowns may have on the population?
In terms of cardiovascular effects, I think one thing which we need to look at is look at both the good news and the bad news. I was talking to a cardiologist in Kerala who's part of the Cardiology Society of India, and they have estimated that there is almost a 25% reduction in emergency admissions. This could be access to healthcare, because if you look at the CREATE registry, which was published around 10 years back, showed that 60 to 70% of people use some form of public transport or their own private transport to reach hospital. Now, without the public transport, they may not be reaching the hospital. The second thing is the elderly and women generally are very reticent to go to hospitals. And in fact, if you look at the registries, they have very low women patients. And the elderly, it's a society which says, oh, I have become old, so I don't have to, I've finished my innings, I've done everything in my life, I don't have to go to the hospital. The third is that people with lesser symptoms, people with milder symptoms may not be going to the hospital because of the lockdown issue, or on their own, they may not be going to the hospital. Then there are issues in relation to compliance to drugs, particularly hypertension, anti-diabetics, are quite poor in India. And given the fact that it takes a huge amount of effort going and getting medicines from the pharmacies, they may not be going and getting. So it may have a longer term impact. Some of the medicines are supplied by government hospitals. And again, here there is an issue of how do we go and get those medicines. So I think these are some of the major reasons that things have changed. The other thing that has changed is interventions have really come down. I think people are saying for acute myocardial infarction, it's TPA that is being given in most places. And the intervention rates, even in ACS, has considerably reduced in this part of the world. So all these will have long-term effects. It's too early to say what the effects are going to be. Actually, we are starting a registry in collaboration with the World Heart Federation. It's going to be an international registry to look at cardiovascular manifestations of COVID, and that will give some information.
Great. Thank you so much. Dr. Agarwal, wanted to switch over to you. So how has your institution approached design and implementation given the scope of the pandemic and an urgent need for therapies? Are there novel approaches that the institutions and regulatory bodies in India are deploying that you think we should consider here or other nations?
Yes, so my institute is a very interface institute. We exist in the world of genomics, in the area of disease biology, in the area of data. And our role has more or less been to try to bring things together. So two verticals that we run very heavily at my institute are one in diagnostics and second in digital and molecular surveillance. I'll take the first one first because it's much easier. We are already starting to plan for a situation with lots of asymptomatic people who will require to be tested without waiting for the symptoms to come up. So you'd have to look at almost new modalities of testing. You'd have to have basically paper strip based testing. You need to have massive NGS based 10,000 tests done for screening at once. So that's one area where my institute has been asked by the government to focus. Plan ahead. So later on, if the country needs to do 50,000, 100,000 tests a day, how would we do it? And given, as Dr. Prabhakaran pointed out, we are a very large country. We are a very dense country. If it turns out that asymptomatic people need to be tested, a lot of strategies, starting from how to pool samples, starting from how to barcode samples, starting from any way in which you can get 100,000 tests done per center per day. Those kind of things are what we are working on. The second aspect of what we do is digital molecular surveillance. Basically, what it means is we are surveying the virus. We are surveying the sequence of the virus as it mutates, as various strains come, providing this information back to our ID surveillance programs so they can look at linkages between things. We are also trying to set up entire channels for long data collection and integrate them together to see how are patients getting infected, where are they getting infected, take data from Arogya Setu, try to see whether on-ground testing strategies from diagnostics can supplement that information, try to create a model for how the country can logically and scientifically open up and shut down at the right times. Stay open for as long as it can without creating undue risk to the people, and then at a suitable marker, start shutting down so that you can protect the people who are most vulnerable. And the last part, of course, is the biology part. We are trying to understand the host response to the virus. We are trying to see whether people may have different protections based on their genetic background, for example, the AS2 receptor variations. So the viral host interaction is something we are looking at. And all that information is being fed to the people working on diagnostics and diseases and treatments. So for example, we can start seeing that the N gene primers are starting to show mutation binding sites. So maybe the diagnostics need to be changed a little bit better. The interpretations need to change. We are looking at the vaccine targets. Are mutations coming over there? We are looking at the drug targets. Are the mutations starting to come over there? So far, nothing much, but it's an active program. It's not a passive one. So I would actually say something I think that Prabhakaran said very well. The thing I have noticed different about the Indian response is that we have a plan. We have resource limitations. We may have difficulty in fully implementing the scales of the plans we are talking about, but there is a very powerful, active, highly discussed plans coordinated between multiple agencies. Ultimately, resources might be the determining factor, but we are trying to make the most of what we have.
Great. Thank you so much. One other question that we had was, how do you see COVID-associated acute cardiopulmonary risk being managed in India, given elevated risk profile for chronic cardiopulmonary disease within India?
Yes, I mean, so when we first heard about the coronary deaths occurring around the world, and given that India has a high chronic cardiopulmonary disease anyway, and the people are high risk, we thought it might present much worse. Like I said, we don't treat patients ourselves, but we have access to data coming from places, and we are in conversation with lots of places, even before the data is flowing. And we are finding that apart from the acute deaths that occur in the first 24 hours when people come crashing, and a lot of that seems to be cardiac. Once people have come in, people have been stabilized, the outcomes are actually not bad at all. If you look at the person fatality rate in India, it's closer to 3% compared to what you are seeing in America. Now that could have only 2 or 3 explanations, and I think Prabhakaran went to that already. One is that we are having better outcomes. Number 2, our denominator is better. So we are finding more people. There is no way to answer which one is correct. You would have expected with our high coronary risk that perhaps the outcomes would be more severe. But by and large, we are not seeing it at all. And one thing that is possibly going in our favor is we have had time to prepare based on the lockdown and the learning from experiences in America and Italy and many other parts of the world. So the simplest example I can give, I was speaking to one of the premier centers. We have learned that coagulation seems to be important. We have learned that our protocols need to include that possibility. We have learned that possibly checking for D-dimer and starting anticoagulants may make the difference. In America, you didn't know that in the first month when it all started. So we are trying to learn from other people's experiences.
One last question I wanted to pose to both of you is, how do you see us moving forward? How do you see India moving forward in handling this pandemic? Dr. Prabhakaran, I'd like to start with you, and then we'll go on to Dr. Agarwal.
Right. Thank you, Dr. Sinha. I think we can look at it in multiple ways in terms of what needs to be done. One is at the public health level. how do we, open up the lockdown? So I think what is required is a calibrated approach, and the government is thinking in terms of doing that, creating zones which are red, yellow, and green, where green would allow normal activity except for people wearing masks, because masks are going to stay and masks are going to become compulsory, so that it protects the people as well as protects others. The second is in the red zones, the lockdown will continue to be there, and stringent measures will be there. The second is the screening techniques. The people are going to use syndromic approaches. Any upper respiratory, lower respiratory infection will be screened, and their contacts traced and quarantined or isolated. In terms of testing, pool testing, etc., I will leave it to Dr. Agarwal to answer that question. But also we require some management protocols. It's a very dynamic process, and as Dr. Agarwal pointed out, the management protocols needs to keep changing as and when the science gives us new evidence. Then there are lots of issues in terms of supply chain things and disposing of biological waste, so on and so forth. So those are also being prepared, and we have been part of preparing a guideline for waste disposal. Our environment team has been doing that. And increasing the personal protection equipment supply is one other area, and increased provision of oxygen. How do we do that? Because that seems to be an important area to be covered now. I think these are some random suggestions or random thoughts as to how the country will move forward. Hand it over to Dr. Agarwal.
I think the only things I would say, in addition to what has already been very articulately said, we will need better and wider testing protocols so that we can best identify those people who are infected, bring them into quarantine so they don't infect others. And we need to have rapid digital platforms so information flows rapidly and decisions can be taken rapidly. There is no point testing a large number of people and having somebody read that information 7 days later when it's already happened. So almost real-time digital platforms, actionable information coming from wide and broad testing, and of course better management. And I think India is uniquely capable of that, given a very, very strong digital base and platforms, and of course scientific innovation on top of it to guide everything continuously.
Dr. Prabhakaran, Dr. Agarwal, thank you so much for taking the time to join us today and for being on the front lines against COVID-19. We really appreciate the insights you've shared with us today. And I think we would like to thank you again for taking care of our patients and making such a difference.